Hi everyone, this is Medicine in Minutes. Welcome back to my channel. So today I would like to share an experience about a patient that I have come across very recently and found to be very interesting for you all to hear. So this is about a 26 years old male patient who has presented to me with day 2 fever with arthralgia and myalgia. And he was previously unevaluated and healthy patient. And he was also complaining of a left-sided chest pain with cough and cold. He doesn't have any shortness of breath, orthopnea or exertional dyspnea. So on further evaluation of the chest pain, I have found out that the chest pain was pricking type in nature. It was increasing by coughing and deep inspiration, and it was decreased by leaning forward and sitting up. The pain was non-radiating and the pain was not associated with any autonomic features. So it was all alarming for me to suspect pericarditis. So I further evaluate. On examination, I have found out that the patient's blood pressure was 120/80, which was absolutely normal, but his pulse rate was 125 beats per minute with regular pattern, which means the patient was having tachycardia without a fever. His saturation was 99% on air, his lungs were absolutely clear, his JVP is not elevated, he doesn't have pulsatile liver, he doesn't have bilateral overlap edema, he doesn't have any murmurs, which means he doesn't have any features of congestive cardiac failure. So in the suspicion of pericarditis, I have done an ECG to that patient. And I was expecting for him to have the pericarditis changes in the ECG. Instead, I have found out the patient was having different sizes of complexes in each leads of the ECGs, which is known as electrical alternans, which is a pathognomic sign for pericardial effusion. So I have done the bedside 2D echo immediately and found out that the patient was having mild to moderate pericardial effusion. But fortunately, patient was not having any features of cardiac tamponade such as Kussmaul's sign or hypotension. For the reference, what is Kussmaul's sign? So Kussmaul's sign is a sign which can be found in pericardial effusion plus cardiac tamponade, which means usually our JVP drops during inspiration due to negative intrathoracic pressure. Instead, if the JVP paradoxically rises during inspiration, we call it Kussmaul's sign. And what is cardiac tamponade? So we have a misunderstanding that for a person to get cardiac tamponade, there should be a large volume of fluid to be filled in cardiac sac or pericardial sac. No, that is wrong. That is misunderstanding. So basically cardiac tamponade means any kind of fluid at any amount as little as 100 to 150 milliliter is filled in the cardiac or pericardial sac, causing a severe diastolic dysfunction, results in hypotension, is known as cardiac tamponade. So please do understand that. So as we have discussed, the patient doesn't have any features of cardiac tamponade. As you can see in the ECG, even though there are changes for pericardial effusion in the ECG, there are mild ST elevation in V1 to V4 and J-point ST elevation 2-3 AVF, which indicates a mild pericarditis as well. So the cause for the pericardial effusion in this patient was initial pericarditis due to the viral infection. So we have excluded the bleeding manifestation and platelet dysfunction, and then we have started him on NSAIDs. So with the treatment with NSAIDs, he gradually improved, and after the 5th day of the treatment, he was symptoms free, and then we have repeated the 2D echo, and the pericardial effusion was completely resolved, and the pericarditis features also completely resolved, and then patient was sent home. So again, what I am trying to emphasize is, especially for the medical students and the budding doctors, please do stick with your basics. Always try to improve your history taking skills, always try to improve your clinical examination skills, and always try to improve your ECG reading skills, which will give you most of the diagnosis. Please do stick with your basics. Thank you.